In the next session, I just want to start off by throwing a fun fact, or a reminder, and that is that according to the World Health Organization, 1 in every 8 people worldwide are migrants. Around 83 million people worldwide have been forcibly displaced, and that's equivalent to the entire population of Germany. And these people are among the most vulnerable. 30 to 40% of them suffer from anxiety, depression, or post-traumatic disorder. They are more prone to contracting infectious diseases like tuberculosis, polio, and malaria. Because 50% of them don't have access to basic care, and they also are more prone to get any waterborne diseases because they're always on temporary shelters. So while public and NGO efforts are growing, they're still in the very early stages. So now join us as we dissect the difficulties of healthcare during migration and explore some of the best practices to navigate these challenges. Before we start the session, we do have a question for you, and that is by scanning the QR code. NCD risk factors are exacerbated by? You scan the QR code, answer with the best possible option, and you'll have to stick around until the end to be able to compare the answers. At the end of the session, we will also have a very short Q&A part, and we want to kindly remind you to take no more than 15 seconds to pose your questions, and that way we can allow as many people as possible to answer them. So without further ado, let me introduce you to the moderator of this session, Luis Eugenio de Souza. He has a strong background in health policy and management and has been a key figure in public health. For the past 2 years, he has been president of the World Federation of Public Health Associations. Luis Eugenio has served as a municipal secretary of health in Salvador Bahia, director of the Department of Science and Technology at the Ministry of Health. Please welcome Professor Luis Eugenio de Souza.
Thank you very much. I want to congratulate and thank you, the Geneva Health Forum, for organizing this event and this session on migration, health, and equity, and for inviting me to represent the World Federation of Public Health Associations. It's a professional society representing over 5 million public health professionals worldwide. The WFPAGA has 139 associate members, including national public health associations, public health schools, and international partners. The current world health situation can be characterized as a syndemic, a set of linked health problems involving several afflictions and their determinants, interacting synergistically. Among these determinants, wars, violence, that includes forced displacement, and environmental issues related to the climate crisis are prominent, as they jeopardize the continuity of life on the planet and increase social and health inequities. These factors endanger life's continuity on Earth and contribute to social and health disparities. To tackle this complex challenge, the World Federation of Public Health Associations renewed this mission recently, which now reads as protecting people and the planet, preventing diseases, and promoting health, peace, and well-being. Along with this mission, the World Federation goes centered around advocating for peace, promoting sustainable health equity, decolonizing public health, and developing global policies aimed at enhancing the health of populations and the planet. Undoubtedly, migration is a crucial theme for the public health field. Ensuring continuity of care at the different stages of the migration process is an especially difficult task. That's why we are having this third session of these days that titles itself, Ensuring Continuity of Care at Different Stages of the Migration Process. To compose this panel, I'm delighted to invite our distinguished speakers, Alexios Georgalis from the National Kapodistria University of Athens, currently pursuing a doctorate in social psychology. Alexios holds a Master of Science in Education and a recent mandate for the United Nations and UNICEF as co-author of the Boys on the Move Life Skills Curriculum. Thank you for coming, Alexios. I'd like to applaud
Thank you very much.
The audience for him. I'd like also to invite Reynaldo Ortonhan from Doctors Without Borders. Reynaldo is a medical doctor with a master in tropical medicine and disease, and since June 2022, he has been the Doctors Without Borders medical coordinator for Mexico and Central America. Thank you for coming, Reynaldo.
Thank you.
It's my pleasure to invite also Rebecca Marcussen-Lewis from the SOS Méditerranée. Rebecca is a clinical midwife and medical team leader coordinating medical response on board at a search and rescue vessel. Thank you for coming, Rebecca. You're welcome. And finally, it's my pleasure to invite Sanjula Veerasinghe, who is the global coordinator on migration and displacement at the International Federation of the Red Cross and Red Crescent Societies. Please welcome Sanjula. We decided among us to make a kind of quick conversation with short answers, so we're going to have some rounds of discussions and have some time to open for questions from the floor, from the audience. So I would like to make a first question, a very general question related to the general theme of our panel. That's related exactly for how to ensure. So I would ask you for a brief comment at this moment, before if you would like to introduce yourself more specifically with some issue that I have not mentioned as your general role here in the panel. So please, Alexio, would you like to say something about you? What do you stand for?
All right, I'll begin. Thank you very much for having me on the panel. This is a great honor to be here among colleagues. So I will first focus on describing the different stages of migration process as seen while working in different countries with my colleague and mentor, Mr. Thompson. So different countries and different refugees routes to develop Boys on the Move, which is an intervention addressing specific health and protection needs in boys in migrant situations. So you can also have a look at the poster on the forum website presenting the 12 questions and answers on sexual and reproductive health and rights developed for UNFPA and UNICEF, which is like our example of good practice on addressing the health need of migrants, particularly in crisis situations, in a staged manner. So, but we can discuss this later in the session. So back to addressing the hardships of refugees faced during the different migration phases. My contribution centers around matching the unique health challenges faced by refugees during the migratory journeys, including the often overlooked sexual and reproductive health and rights, as also mental health. Continuous health care to refugees, especially the most vulnerable, such as unaccompanied boys, and we can get back to that, is very complex but crucial, as health risks include the hazardous journey itself, psychosocial stressors, nutritional deficiencies, and infectious diseases. So the dynamic nature of their movement complicates consistent access to services. So I'll share my understanding of the different phases now, and I'll give the word to my colleagues. So we have matching health risks, so to say, and needs across the different migration phases. And migration starts before the actual movement of migrants. So we have the pre-departure phase, where preparation and planning at their home countries takes place. And the refugees are, in fact, motivated to leave by the economic, social, and legal challenges, and the risks that include inadequate access to healthcare. So many will have none to less information on health in general, let alone risks associated with migration, and will avoid even thinking about potential exposure to exploitation and trafficking along their future journey. Then moving on to the transit phase, the actual movement, which varies in duration, route, and mode of transportation. So it may include immigration enforcement control at the international borders, and like real physical barriers, such as fences or natural obstacles. And here we have real life physical hazards, and temporary stops at border crossings, which can lead to violence, injuries. And of course, we have the extreme weather exposure. And we've seen refugees not being prepared for alpine weather, for example, during their move. And of course, limited healthcare access, just as health problems are likely increasing during this phase. If they survive and if they arrive, upon arrival, then we have social integration and access to services, which are often neglected, and either due to facing administrative or legal procedures. And all the challenges in accessing healthcare, education, and social support, include language barriers, lack of documentation, discrimination, or exclusionary policies. So the varying legal statuses of the refugees or migrants in the different countries, including refugee, asylum seeker, documented or undocumented, they impact their rights, including their access to all kinds of services, like also health services, and impact their vulnerability to exploitation and abuse. You may have heard these words in all the phases, so we're facing danger of them being trafficked and exploited. But in the destination phase, the mental health becomes a visible or sometimes invisible issue, as stress, anxiety, and depression due to acculturation challenges, discrimination, or even trauma accumulate. And the final would be the settlement phase, where the chronic health conditions exaggerated by the journey and antecedent determinants, such as poverty, they now interact with inadequate housing or complete lack of access to healthcare. So mental health pathologies such as post-traumatic stress disorder may involve also substance abuse, which is a very, very common case. Behavioral inadaptation to the new environment persists or worsens through the settlement phase. So understanding the dynamics of each migration phase is therefore very, very crucial for our discussion here, but also for the adequate interventions and policies to address the health needs of the people on the move. And given that their journey brings unique challenges and risks at each phase and at each refugee route. So we need to develop comprehensive, contiguous and holistic approaches to promote their well-beings. And I'm really open to your questions, like what do I mean by holistic and contiguous? But let us not overlook a migration phase that is a bit unknown, which could be the return or resettlement, and the continuity of care for returnees, including managing their chronic conditions and reintegration support. There are obviously risks associated with migration. So they also require comprehensive and integrated approaches. So my experiences in the migrant health and healthcare provision in mobile settings underscored the importance of adopting contiguous, holistic, right-based approach, accentuated particularly for vulnerable groups such as adolescent boys. And I put a small point there, but I think I'll have a question on that. The frameworks such as Boys on the Move or 12 Questions and Answers on Sexual and Reproductive Health and Rights provide, in my opinion, the health-promoting knowledge and behavior, dignity and well-being, regardless of the migration status or journey phase. So protection is central to the well-being of refugees, including measures to prevent and respond to sexual and gender-based violence, which is a huge issue on their journey, trafficking, and other forms of exploitation. So efforts that encompass health promotion, disease prevention, early detection, and timely access to information and services, they bring dignity and respect. So I'm going to close my first statement here. And
thank you very much. Alex, you really detailed each one of the stages of the migration process, highlighting the different needs that people have at these different stages. Thank you. I would like to ask Reynaldo to introduce himself briefly and see how do you see this whole panorama of ensuring continuity of care at the different stages of the migration process. Please, Reynaldo Ortuño.
Thank you so much, Luis. I'm the medical coordinator for MSF in Mexico and Central America, which is a different context of what you have seen this morning along Europe migration. And we have been working already for more than 10 years in the region, in Mexico, Guatemala, Honduras, Panama. And I think it's important for sure this panel discussion on continuity of care, because we see a lot of challenges for migrants, particularly accessing care overall in the route, particularly looking at limited access to healthcare in the facilities that sometimes is not even enough for local population. So it is more complicated for sure for migrant population accessing to healthcare for non-communicable diseases, SRH, mental health, and as well there is a lack of actors that are providing care, either institutional or humanitarian in the context that we're working on. So I think to bring you a bit into the context of what is Mexico and Central America, I think there is a deteriorating political, economical, and environmental context. As we see yesterday, climate change is playing an important role as well, as we see some floodings, hurricanes, droughts that is pushing people away, in addition to the security conditions, because it is a context where violence is quite high. And people flee their homes because of violence, not only for economical reasons. And we see this a lot in what we work in the region. So the route that they follow is a struggle to reach United States for better living conditions, but it's not only related to epidemics, chronic illnesses, physical injuries, or mental disorders. There is as well a lot of serious human rights violations that includes physical violence, robberies, extortion, kidnapping. Organized crime is really behind migrants now, and that includes sexual violence. That is as well part of it, and we see this increase as well in our context in the latest period, that I will talk about figures as well a bit later. So all of that is coming together with an unprecedented migration flow, as we see an increase that is really high. If we compare previous figures, in 2023, for example, there was 520,000 people crossing the Darien jungle, and that's already 110% more compared to 2022. And we know that the Darien jungle is quite complicated because of the conditions. There is no place for migrants to sleep, and there is no shelters. They suffer violence, they suffer sexual violence, and it is for sure a challenging environment for migrants overall. We see as well that there was an increase of apprehensions in the border between the United States and Mexico. 300,000 apprehensions happened until December alone last year. So this is in a border that is considered the most dangerous in the world, as I was saying about kidnapping and all the different challenges that they have as well. So we as MSF, we are working in different points along this route. And what we are trying to do is we have a multidisciplinary team that is composed by doctors, nurses, psychologists, health promoters, social workers, that provide primary health care, sexual reproductive health, non-communicable diseases treatment, mental health, and prevention as well at the same time than curative services. So our teams are moving along these different locations in shelters, bus terminals, makeshift camps, and health centers where there is no health care provided, not even for local populations sometimes. I think I'll stop here and I continue later with some figures of what we do or what they have done in the previous years as well. Thank you.
Thank you very much, Ronaldo. I would like to go now to Rebecca to introduce herself and say the first words about our general theme. Please, Rebecca.
So, as said before, I work on board a search and rescue ship in the Central Mediterranean for SOS Mediterranean. And what we see is a very visceral demonstration of what Alexis was saying earlier about the different phases in the migratory pathway. So we're quite a unique environment. It's very intense and it's very short. It's very much that transitory phase. It's one of the riskiest moments in the migration pathway. And our main objective is actually to save their life in this moment. And we're set up as an emergency service. We describe ourselves a little bit as an ambulance of the sea. However, what we also see is that we are providing more comprehensive healthcare because we are having to bridge a gap or a lack of continuity of care in their pathway. We've been operating in the Central Mediterranean since 2016. Currently, we're in partnership with the IFRC on board, and we've rescued over 40,000 people in this time. However, the last year was the deadliest year in the Central Mediterranean since 2017. The actual true number of deaths in the Central Mediterranean is unknown. We don't know how many people have lost their lives at sea. The official figure sits at over 30,000. But because we don't know how many people have tried to cross the Central Mediterranean, we will never know how many people didn't make it to land the other side. The majority of the people that we rescue depart from Northern Africa, so departing from Libya, from Tunisia, and we have also rescued people that have come from Turkey. And because we are rescuing them in this very acute phase, we are also privy to their journey before they attempt to cross the Central Mediterranean. So we also bear witness to their journeys across the Sahara and through Libya. Through this, we are aware of barriers to their access to healthcare. We have testimonies from them about what is stopping them from accessing healthcare along their journey and why we are seeing an exacerbation in chronic conditions, simple conditions that have left untreated and have now grown into much bigger conditions. And we know that their access to care along the way is not only difficult to access, but we also know that in countries of departure for the journey, they are facing violence if they are sick. So this is actually making it much harder for them to trust medical professionals as well when they come and join us. Despite this, in 2022, we actually conducted over 2,500 medical consultations, and over 85% of the people that we rescued received a diagnosis on board. So it shows how high the medical needs are in these people, and that the needs far outweigh the services that we are able to provide. We also then, to try and bridge this gap in continuity of care, we try and refer them when they go to land. However, we do see that very discriminatory healthcare policies across Europe are also acting as a barrier to care, because although we try and refer them, some of them are very scared about being referred, worried that it will impact their onward journey. We see that land and border health authorities can be very keen to help, but what happens to them after in reception centres, on land, in different countries, can vary greatly. One of the things that has helped us is being in collaboration with other organisations and increasing and strengthening partnerships with other organisations like IFRC and being able to ensure a level of follow-up that way. But there is a huge lack in the collaboration between states because of the stigmatisation of people on the move.
Thank you, Rebecca. And I would like to invite Sanjula to present herself and talk about how do you see the challenges to ensuring continuity of care at all the different stages of the process.
Thanks, Lewis, and hello, everybody. It's my pleasure to be here. I feel like a bit of a fish out of water, actually, because I have legal training and I can see that I'm amongst a cast of medical and health professionals. But my background is in migration and displacement, and I've been working on that issue for about 20 years. So I hope that I can contribute to this discussion about continuative care. And having heard my colleagues speak already, there are kind of two things I want to really highlight to you over the course of this discussion. One of them is about why the International Federation of the Red Cross and Red Crescent is critical to this conversation as the world's largest humanitarian network with 191 national societies located all over the world, providing health services to migrants and the population at large. And I want to also highlight some of the insights we've learned from our practice across the globe, including, as Rebecca highlighted, in the Mediterranean Sea, which we call our humanitarian service point at sea. But even before I get to that, I think what I'd like to talk about is this concept or phrase of continuity of care. I think among medical and health professionals, you might have a certain conception of it, and I'd like to elaborate on it from a legal and a migrant's journeys perspective, emphasising a little bit more what Alexios said. So I think there are a number of different transitions when we're considering continuity of care. And one of them is really about the geographical journey. There's a transition from the place of origin to the place of transit and how you manage continuity of care from that first place to the transit locations. There's a transition from transit to places of destination, and that transit location could be on land or at sea, could be all along land in hospitable environments, and then people are arriving at places of destination. There is another transition in terms of a place of destination and being returned or choosing to go back. People might go back to their place of origin, and this phrase around continuity of care becomes relevant there. People might also be deported or returned to third countries. And there's a consideration around what type of continuity of care is possible when that transition happens. So continuity of care, as we're thinking about it, relates to the geographical journey. And then there are another set of transitions as it relates to the intensity of the crisis. So you can think about shifts from non-crisis situations to Ukraine, to Sudan, to other crises and disasters that are happening in the world. How do you scale up continuity of care from a non-crisis situation to a crisis situation? And how do you scale down again if that's what's needed when the crisis abates and you go back to non-crisis context and you can potentially service migrants' longer-term needs better and in a more holistic way? So there's the geographical dimension, there's the intensity dimension, and then there's another dimension which is related to continuity of care in places of settlement. And those places of settlement may include camps for refugees, may include camps for IDPs. They can include detention centres, they can include reception and accommodation centres, and they can include places where migrants live with some level of freedom of movement. Status in that context becomes quite relevant. Are they documented or not? Do they have freedom of movement or not? Do they have the relevant attributes to be able to access care? And what does the legal environment and the regulatory environment allow? So I think unpacking this concept is really important because through our different disciplines, we come at it from different angles. And through my discipline, those are the different transitions that I think about when I think of continuity of care. And then just another conceptual dimension that I want to highlight before handing over back to Lewis, and hope that I still have time to talk about what the Red Cross and Red Crescent does. But another kind of conceptual dimension we need to think about is whose perspective are we looking at when we're thinking of continuity of care? Are we looking at it from the perspective of the needs of migrants, their risk profile, their health profile? Have we asked them questions about what they need, what they know about their health background? Have we done an assessment? The needs of migrants. Is it about the capacities and opportunities for service providers to provide continuity of care, the capacities and resources for service providers? Is it about the coordination and governance challenges when it comes to continuity of care? In effect, it's about all of them. And so as we're thinking about the actions, the insights and the interventions that are relevant to this discussion, we also need to highlight which perspective we're coming from and how those different perspectives come together as a collective whole. So those are the conceptual points I just wanted to make as an introductory set of remarks. I'd love to be able to touch upon later on what we do and why we're relevant to this conversation. Thanks.
Thank you very much, Sanjula. As we see, you have a great group of people who are in the, maybe say, in the front line of the work with their hands on. And sometimes I can see very stressful jobs to do, but also experienced people with some years of work on it in the work of trying to coordinate all the efforts that are necessary to face the needs of the people in the migration process. But I would like to go to a second round of more specific questions for each one of you, starting with Alexius, that works with unaccompanied boys and young men on the move. And say something, teach us about how can we, as societies, can address the specific situation of unaccompanied boys and young men that are on the move. What are your thoughts about it?
Right, thank you for this question. You could have prepared me. So I was expecting this question because it's often that if you make an interventional program and it's targeted on boys, then you get the question like, what about girls? So it's addressing gender-specific health needs is, first of all, very important. The first reason would be statistics. So in the case of Greece, we had an influx, about 90% of the refugees coming in, they were male. And the age span was like I don't know, the 12 to 32, but it was like about 90% of the people in the movement, at least in our areas, was male. And it was a neglected population, so to say, and often seen just as perpetrators or as a legal problem, so to say. And so if one develops, so my suggestion is that we should develop more gender-sensitive healthcare programs that address the unique sexual and reproductive health needs of refugee men or refugee women. So it has to be a bit divided. So you cannot make universal packages for everyone. And by addressing the boys and men, this is what we say, like a bit romantic, making them to agents of change. So it was like what you said, like asking them their opinions or what they are carrying with them, cultural barriers or what they would, difficulties on adaptation. So gender-specific packages, and there was on neglected, I would say, populations as the unaccompanied boys. It's of great importance, and this is how my career, I would say, started, because we had this huge scandal never seen before in the European Union where young boys from 12 to 16, 17 would get trafficked when I said would get, because there was not a trafficking mafia to be seen, so to say, but they were prostituting on survival sex, and it was in Athens, 2015. So it was a huge shock for the European Union. So something had to be done for this specific group. And again, going back to the statistics that we have, that like really seldom unaccompanied young girls, like literally walking around Europe as the young boys did.
Thank you. Thank you. Very touching problem. No doubt. I would like to go to Reynaldo. Reynaldo, as we know, the Doctors Without Borders is highly concerned about the violence and insecurity on the migration route worldwide. And you just mentioned that going through Central America, after traversing the Darien jungle is already something very violent. It's by itself, we can say that each migrant that is able to get alive at the other point, at the other side of the Darien jungle is already someone very strong, even though they will suffer another case of violence, and you mentioned the narco trafficking, and it's all that during their way in Central America. So what your experience in this can teach us about to deal with this enormous challenge of providing safety, security for the migrants in their way on the move?
Thank you for the question. Yeah, I think from our experience, what we see and what we try as well to do in order to prevent as well migrants not accessing to healthcare is to try to work with travel kit medicine. Because for sure, if there is a person coming with a non-communicable disease, diabetes, hypertension, and they are having challenges to access their medication because, as I mentioned, the cultural barriers, violence, accessibility to health facilities, distance, language as well, which is a great challenge because we have like 30% of Asians that only speak Creole, for example, that cannot access to healthcare. So we are working with travel medicine kits for non-communicable diseases or mental health, and MHGAP as well, which we have developed in 2023, where we have managed to train doctors, psychologists, supervised by a psychiatrist, and being able to provide basic medication for psychiatric conditions. And all this is helping as well to guarantee continuity of care on the route. For sure, there is plenty of barriers that we cannot tackle, considering the levels of violence. And as I was mentioning, sexual violence is one of those, where we see a huge increase in the last year. In 2023, we have assisted 232 sexual violence cases. Out of them, only 10% were in the first 72 hours. And in 2024, only in the first trimester, we have seen already 251 cases of sexual violence, and only 13% in the first 72 hours. And we all know how important it is to have comprehensive care in the first 72 hours to prevent HIV, STIs, and unwanted pregnancies. No? So I think it's an important point to still try to find ways to cover this population and to be able to work in preventive packages and adapted strategies to guarantee the continuity of care. And as well considering as well the lack of actors and the lack of solutions at the moment, because there is political commitments, there is policies in place to guarantee access to healthcare, but sometimes at health facility levels they are not aware and they are not providing care to migrants themselves. So we have to accompany, navigate migrants to help them to get secondary care, for example. So I think there is some mechanism that we can work on to support into that.
Thank you. Yes, it's not easy to deal with the deadliest border in the world. You see it between Central Mexico and the U.S. Your challenge is not small, of course. Rebecca, and you mentioned the risk part, the riskier part maybe of the migration process when they are in the transit. Also, we know that the Mediterranean is a grave for thousands of people. And what should be done? Of course, you are doing a great job and very important work. How could society as a whole support you in this so important activity of saving lives?
Well, what we see is, at the moment, we are now treating people as numbers or as a problem. We've stopped seeing them as individuals. we've stopped seeing them as people. Instead, all we see is a migration problem, a migration crisis. And while we continue to stigmatize people on the move, we continue to sacrifice their health, their life and well-being, saying that it's less important than their legal status. What we also see is an increasing lack of safe pathways for people to move to safe areas. I mean, we can see this throughout Europe, we can see this throughout the world. And if there isn't a safe pathway when people need to escape and they need to flee, they will find another way. One of the ways that I always describe it, and forgive me to go back to my midwife roots, is what would drive a mother that had a cesarean section 5 days ago to get into a rubber boat that I wouldn't get in for a day trip off Brixham and try and cross the central Mediterranean, where she stayed for 5 days until we found her. It's people only put their children at sea when the sea is safer than the land. It is the riskiest part, and it's being made riskier by the criminalization not only of the people on the move, but also of the people who are trying to help. We have seen in recent years increasing criminalization of NGOs at sea. What we actually follow is a very, very old search and rescue mechanism that is worldwide. You know, there is a legal obligation for every captain to rescue people in distress if they are in the vicinity. And what we're seeing is the manipulation of maritime mechanisms of inspection used to detain ships. We're seeing the introduction of new punitive legislation to try and prevent ships from going to sea. In the last year, we have been blocked for 60 days from going to rescue people. In terms of lives, we don't know how many lives that could be. And we're not the only search and rescue asset that has been blocked multiple times from saving lives. We've also seen court cases that have been ongoing for years. One has only recently been resolved after many years and has been told that it was unfounded, that there was no reason for them to be in court after so many years. So until we stop focusing on people's legal status and we start going, this is a human that needs help, this could be my brother, this could be my brother's best friend, this could be my little sister, and see them as a human, we're not going to be able to prioritize their healthcare and their well-being. And the world is really small, not to get very heavy with you, but the world is very small. We can't ever guarantee that we're not the ones that are going to need help. We can't be the only ones that are trying to save lives, and we certainly can't do it if people are trying to block us at every stage. We can't then even keep doing what we're doing, let alone try and improve the outcomes that we are having.
Thank you very much, Rebecca. It's so important, your testimony, because we see that the human rights can be something practical. We are maybe tired of listening to so many political authorities using it just rhetorically, but if you can do something practically, it can be a value shared worldwide. Thank you very much for your thoughts. And then, Sanjula, you, the International Federation of Red Cross, Red Crescent Societies, is an essential organization with much experience helping people in difficult situations for a long period already. So, from your point of view, from the point of view of the International Federation of Red Cross and Red Crescent, how could we improve our way of dealing with this conflict? Is it possible at a certain moment to touch the root cause of this problem?
Thanks, Lewis. I don't know how much you all know about the International Federation of the Red Cross and Red Crescent Societies in our network, so maybe I'll answer that question after I tell you a little bit about us. Maybe you've worked with your national society in your domestic context, or maybe you've seen the IFRC Secretariat playing its representative role in different locations. But just so you know, we are a global humanitarian network, and as I said, there are 191 national societies in every region of the world. And not only that, there's an expansive network of close to 200,000 branches in the territories of those 191 countries. So what that essentially means is that we are not only in the countries of origin, transit, and destination, but we are also in the locations of origin, transit, destination, and return of migrants. We're in the rural communities, we're in the border areas, we're in the capitals, and we're in the inhospitable areas that are often hard to access. So what that allows us, what that gives us, is an unprecedented reach and a network to be able to do this type of work. And maybe you know this history, but we were, as a network, as a federation, established in the aftermath of the First World War and as a result of the consequences of the 2018 influenza pandemic. And we've been doing this work, supporting the health and well-being of migrants for over a century, supporting the health and well-being of communities for over a century. And our mandate is essentially to alleviate suffering and contribute to peace and prosperity. And that includes alleviating the suffering of people who are the most vulnerable. And so we've been working with migrants and supporting migrants for just as long. It's an opportune time for us in many ways to work at this intersection between health and migration, because we have a new strategy, a Strategy 2030, which sets out 5 global priorities. And in there, one is focused on health and well-being, and the other one is focused on support to migrants. So that intersection is a critical intersection for us, and our national societies are working on it. We know so far that 165 national societies are providing services to migrants, and of those, about 100 are providing healthcare services. And they're working in emergency contexts, they're working in non-crisis contexts, they're working in camps and settlements and reception centres, and they're working more generally in communities to foster inclusion and social cohesion. So this work is in our bones, it's in our national societies, but it's also a strategic priority. And I'm just going to give you 2 quick examples of what's particularly relevant here. Rebecca already talked about our partnership on the SOS Mediterranean, and I hinted at this word, humanitarian service points. This is a flagship initiative of the IFRC, and what it is essentially is a location, a space, where migrants, irrespective of their status, can come and access essential services, including health services, first aid and other health services. And there are hundreds of humanitarian service points across the globe along land-based migration routes and one at sea on board the Ocean Viking ship. And what we do here is provide the low-cost, immediate care that migrants need. First aid, mental health and psychosocial support, information about where to access additional services, connectivity and support to stay attached to family and friends, and spaces to rest and get the basic support that they need. So this is one of the main ways in which we are addressing continuity of care as it relates to the journey, as it relates to people moving from one location to another across inhospitable terrain. Too loud? Across inhospitable terrain. And this is one of the ways in which we want to continue to strengthen support and continuity of care along routes. Another dimension I just want to touch upon is in relation to the scale of global health facilities that we have as a network. So we just conducted a recent mapping that showed that we have 49,500 global health facilities across the world where professional staff trained in the medical profession are providing services to communities. Now, they're not providing services specific to migrants, but they're providing services to communities. And we have a principle-based approach to providing care, which means it's impartial, and we do not discriminate based on status. So there are 49,500 professional healthcare facilities across the globe, and I'm sorry, I've got that number wrong. There's 4,500 healthcare facilities across the globe and 49,500 healthcare professionals providing those services. So one of the other things that we need to do better is to bridge between our different forms of service provision. We have these humanitarian service points, which are providing immediate needs and care, and then we need to, as a collective, work out how to make those referrals to the professional services that are also provided, not within our network, not only within our network, but also across our partners. Thanks.
Thank you very much. Impressive the work that the Federation of Red Cross and Red Crescent has been doing all this time with these figures and the quality of service that's provided. But in the previous sessions of these days, one issue that was mentioned several times, maybe I would like to hear from you, from your experience. It's clear that the health sector alone cannot deal with this problem of assuring the right to health for the migrant people. In your experience, how does it function? Do you have experience working across sectors with other organizations or governmental or non-governmental organizations that are not from the health sectors? I don't know if Alexius would like to start again.
So this is for sure a key to success, like ensuring cooperation, but it's a very difficult task. So from what I've witnessed, also inside the UN system, for example, it's not that easy to get different organizations to work together. And so let's not talk about getting different nations working together, and even nations that are not friendly to each other sometimes. So I'm not an expert in policy making, but I like witnessed the problems that one can take.
Okay.
And since I'm not an expert in policy making, so like my contribution on that would be, since my background is on education and psychology, when I was like really thinking like what can I contribute to this panel, so my contribution on that would be changing the person. So education and a change in perspective and behavior is the only thing that they can take with them on a journey. So I'm on like changing the individual without giving the responsibility to the individual refugee. No? But, so my experience is getting cooperation is very difficult. It's being carried out, and at some point we see a wonderful example here with your organization cooperating. But I see the struggles, and between nations even stronger. So I'll take it like back to the individual on like educating and supporting individuals to take care of their continuity of health.
Ronaldo, what about your experience in working across sectors?
Well, I think, there is need of more efforts, definitely, considering the lack of different services available for migrant population. If we see, for example, in Central America, in terms of shelter, sometimes they are overcrowded and there is not enough capacity to host all the different migrants. And some of them stay outside in difficult conditions that depending on the weather and the period of the year with climate change could be either too freeze, too cold, or too hot. Wash and sanitation, it is a challenge, and we see not enough water and safe drinking water. And that's why we see as well in our main causes of consultation, diarrheal infection is one of the top because they do not safe access to water. So I think in terms of water and sanitation, there is a clear gap in what we see overall. In terms of protection, I think as well, because of the violence, there is some support, but I think a lot more is needed. Security, particularly for migrant population. And if we see the different politics of the different governments, they are more and more restrictive every time, trying to prevent migrants to migrate. But what they are doing is adding more challenges and more risks for them in the road because they are extortion, they are kidnapped and so on. And that's coming because of the different policies that are not in favor of protecting migrants because they should have a free passage, no? And that's not what we see. So I think there is still a lot more that can be done in terms of ensuring the access and security and protection for migrants because it's their right as well to migrate as they work. Thank you.
Thank you, thank you. I can imagine all the challenges working public health and police and armed forces. That would be an important partnership to build on, but it is a real challenge. Please, Rebecca, I know you have experience in working across sectors. Tell us.
I mean, I've already mentioned elements of it already. I mean, what we do see is very good collaboration across non-governmental organizations, other actors in the area. Not only do we have the partnership with IFRC, there are other ships, for example, run by Doctors Without Borders, MSF in the area, other organizations there, and we have at times collaborated on difficult rescues, so we're working across section there. Particularly at disembarkations, we are referring to other organizations in that way to try and ensure a continuity of care. But also in the acute phases, working with governmental organizations, also we do this as well. We work with land-based authorities in terms of coordinating rescues. This is very different each time. At times it works very well, and at times there is no coordination and we are penalized for that. So we are actually, the lack of this collaboration is then used to penalize us as a non-governmental organization in what we are trying to do. We also see it work very well. For example, in terms of health needs, we're on a ship and at times we are hundreds of nautical miles away from land. We are an ambulance. We are comprised of a doctor, a nurse, a midwife, and a team leader. We can't manage every situation on board, so there are times when we need to evacuate people from the ship. What we do to do this is we utilize a medical evacuation, which is actually, it's a very old mechanism that all ships around the world, whether you're off the coast of South Africa, South America, Australia, they utilize the same system. And this we see works very well because we will get a response from land. I most recently did this in March, where unfortunately we had a mass casualty situation with 2 people in very critical condition. And the governmental organizations immediately sent 2 helicopters before we'd even finished filling in the paperwork. So it can work. However, what we are seeing with the lack of collaboration, I think, is actually the pressure on these states from a lack of wider shared responsibility. What we see in the coastal states, in Greece, in Italy, in Spain, is that they've been left to shoulder the burden of a crisis much bigger than them for too long, without shared responsibility within the EU. This is something that we've been calling for a long time, is shared responsibility, shared assistance, because once too much burden is placed on an individual organization, whether that is governmental, non-governmental, it becomes too much, and then they don't want to help anymore. They become protective of themselves. So what we're seeing through the lack of collaboration is potentially this. And what we need to do is not only increase our collaboration, but support of the organizations that we're asking for the collaboration from as well.
Yes, thank you very much. Shared responsibility and support for all the organizations. The Red Cross, Red Crescent you have already begun to talk about all this collaboration we have across sector. Please.
Yeah, thanks, Lewis. I mean, in many ways, Rebecca's touched upon our collaboration, and it's been a really important one. I think there's a question about collaboration within our movement, given how large we are and the different components within it and the sectors within it, and the collaboration that then we have externally with key partners. And I think when it comes to collaboration within ourselves, just to begin with, we also have to navigate this issue among the sectors that are relevant. So I spoke about HSPs earlier and humanitarian service points that provide services to migrants irrespective of status. And we have these around the globe, but also particularly in the Americas. And some of our national societies have been pioneers in this concept and have pioneered communication between humanitarian service points to share not only information with the migrants about where else they can access services as they go along their journey, but also the types of services that they can access. And so one concrete example among two sectors within our network, for instance, is where migrants come to a humanitarian service point and longer-term or chronic healthcare needs are identified. And some of the national societies in the Americas have identified ways in which to give those migrants cash for care, knowing that they need to continue that journey, they're not going to stay, and are then collaborating with colleagues working in the cash sector to support cash for care and that continuity. Rebecca talked about the disembarkation process. So we have often, with the SOS Mediterranean, the Ocean Viking ship often disembarks, or maybe always disembarks, in Italy. And so the Italian Red Cross is often on the ground supporting those evacuations, supporting those referrals, supporting information about other service providers on the ground when rescued migrants are disembarked. And then another external example is in relation to the Thai Red Cross. There's a large population of undocumented people in Thailand, and when the COVID-19 pandemic occurred, they needed to identify a way to continue to provide the different doses of the COVID-19 vaccine. But there was no way to verify the identity of these undocumented people who were quite reticent to go to authorities and medical professionals. And so one of the things that the Thai Red Cross did together with external partners and with the support of the government was to develop a biometric identification system that scanned irises so that they could continue to get that type of care. And by doing that, that system was then also used to provide subsequent doses of vaccinations for other diseases. And then a challenge, one quick challenge as well. National societies in the Americas have also identified challenges in relation to providing COVID-19 vaccine for transitory migrants, particularly because the booster shots need to happen after an elapse of time. And so there have been complications around the regulatory environment and who's liable for if something goes wrong in terms of that vaccination. So if you provide the first booster in one country and then provide it in another country, who's going to provide the insurance? What does the regulatory environment look like? Who's liable? Anyway, those are some of the kind of challenges and insights from the work. Thanks.
Excellent experience. I think we have seen that it's possible to work across sector, even though there are a lot of challenges and we need more support and more collaboration. I will now change the subject regarding our term of reference for this panel, and I will let you choose which one of you would like to answer this question. But we may wonder if the new technologies can improve your work for each one of your organizations. I mean, the new digital technologies that are widespread in the health sector, using for medical records, using for the telemedicine, used in different ways. Can we imagine that this application, the mobile application, could in some way improve, facilitate access to service for the migrant people, especially in the host countries? Or do you have any experience of it? So I will open the floor for, I don't know, who would like to say something about if you have this experience. And we know that digital technology also pose some threats. It's not a lack of privacy and this kind of problems also. Sajula just mentioned that some people are even afraid to identify themselves. So would be an option, an opportunity, or would be a threat?
Just a small comment. So maybe you were wishing for an answer that AI could solve the refugee problem. But also, like, on my case and on like my part of the discussion here on the panel, So I would wish, and I've seen that the digitalization and gamification of interventional packages, for example, that's my work, could work like really good. So they would have a big impact, since almost every refugee has a smartphone. So it would be surely like a gateway into their into the psyche and into their hands. So I'm not going to like say like having universal medical records that would be accessible in the whole world, because that would be theory. So from my part, just the digitalization of our tools, for example, and the gamification, so that everyone would have access on like a bit of fun, wrapped interventional packages would be like my wish, and then I give it further.
Thank you so much. Indeed, I think we work with different tools from our side. I think digital health promotion is actually one of those, and I think it's indeed, I think a good proportion of migrants, they have smartphones, and it's easy to reach them with some geolocalized, clear target messages that we can send. And that helps them because they can access as well healthcare in locations where they can find in this digital health promotion. We work with tools as well that are QR code with maps where can they access to shelters, access to medicines, non-communicable diseases, psychiatric care that could be easier for them to find in the route that they're working on. And additionally to that, we work as well with referral systems based in applications like Celo that is protected, and then we can send patient files from one location to another so they can continue care in one of the locations that we are seeing. No? It is only for the moment restricted to the sites where we're working on. Ideally, we could have an electronic passport for everyone. That could be an ideal solution, but at the moment it's very limited, and I think these small measures already improve the continuum of care for migrants, and I think more of these tools are necessary in order to continue improving it.
Yes, we have hope.
I'm about to play devil's advocate.
Great.
In that I work in a setting where we don't have connectivity. So everything being digital and online is not so easy for us. And if everything moves in that direction, we run the risk of losing the ability to do it in areas where we don't have that connectivity. I mean, I work on a 69-meter boat, and we've had over 630 people on board. We're not able to provide a connection at that point. However, the thing that is great for that moment is things like telemedicine. Because as I said, we are 4 people, and we are a mix of skills, so being able to have a network that we can reach out to when we have a presentation that none of us has come across before, this is fantastic. And the other side of it with it is a lot of them do have smartphones, but with us, some of them have lost them on the journey. So trying to make these things accessible, but having the fail-safes, I think, is also important. I don't think we should be afraid of digitalizing things. I've seen that a lot, particularly working in the UK. People are very scared of electronic patient records because they're worried, what if the computer system goes down? I don't necessarily think that because our situation is so unique, we should shy away from it. But what we should have is a mechanism for those transitory places where it's not so accessible, can then feed into it. And that then could help with the continuity of care and just make sure that we have those fail-safes for it as well.
Great.
And to just add to that and echo it, to say ideally it would be wonderful if those patient records could be carried by the migrant so that they can take responsibility and have control over their own data. So there are efforts to try and generate that type of record keeping, but that is in many ways the ideal scenario, not only for those migrants who are scared to go to authorities and scared to access services, then they're empowered to be able to determine who they will and won't go to with their own data. But it also helps in the context where that connectivity is not available. But in addition to that more kind of low threshold technology as well, I mean, there are so many apps these days, and many national societies among the network have created apps that enable migrants to determine and understand where they can access services, and to then understand, for instance, if they want mental health and psychosocial care, which can have a stigma associated with it, to determine when and how they access that type of service.
Yes, very good. Actually, you are highlighting that the apps and the technology must be context sensitive. So not only the professional designers, but everybody at the end, users must have a say also in the design, in the technologies that are needed to help them this work. Very good. Before we open the mic for the audience, I'd like to make one last question for you, taking advantage of being here. We heard Professor Bernadette Kumar says this earlier today, that migration is fundamentally a political issue. In the global health, we are discussing the need of decolonizing public health or global health. You know that global health is started like a tropical medicine or hygiene, a kind of approach from the colonizers' countries over the colonized countries. So it's a political issue. Can we take a perspective, a decolonizing perspective of migration, as in putting the political issues that are the root causes? Is this process of migration, of forced displacement, related to the political situation? How do you see that? Please, if you'd like to say something about it.
Hard question.
It's not mandatory, of course.
So that's, first of all, this is an ethical dilemma that I had on are the packages, is the content that we deliver to the refugees. It's made by Europeans, and we're trying to impose something to them. So I have two answers that help me. First, human rights. So it's everything that's human rights based. This is, on my perspective, the right way to go, because I don't think we Europeans have the total right answers regarding family planning, or I don't think that our perspective is the best in the world. But I'm a believer on human rights. So that's my leading point is the human rights. And the second answer would be that I'm a huge fan and supporter of refugee-led health initiatives, and I've witnessed them work. So empowering refugees to actively engage in the healthcare management and the programming, decision making, including their education and the rights and available services. So my answer to that would be to support and empower refugee-led health initiatives and refugee-led organizations, amplifying the voices of the refugees. And if I'm allowed a small anecdotal story, so when we were asked to create a package for the sub-Saharan refugee population of Italy, we were expecting to find 12-year-old boys, as we were used in the Balkan routes, but we confronted older guys, I would say, up to 30, and of course we have this thing many refugees claim to be a bit younger in order to have the service of the countries, and we faced a completely different audience, and our trick, I would say, our gateway to them was what would you suggest to your younger brothers and siblings? What would you consult your younger brother refugees to do or not to do in order to stay safe, for example? And I've seen that working, so I can testify that refugee-led interventions are to the point, effective. Yeah.
Thank you, Alexis. Wells?
Yeah, I can just give a small comment into that. I think what we are trying to do is as well working with the community themselves. So working with the migrants themselves to understand as well how do they want our health approaches to be taken. And that's something that we are trying in our region particularly, that's called PPP. It's patients and populations as partners. So empowering them, working together in strategies and trying to understand how do they want service delivery to be given is helping us as well to understand from their perspective and not as imposing as what we believe is better for them. So I think it's important to consider their voice definitely in creating programs, and that's, I think, the way to go.
Definitively.
Thank you.
Yeah, we just need to stop assuming. We all have our own points of bias. You know, what I have lived, what I've experienced creates my own frame of reference. What Alexios, what Ronaldo, what Sanjula have experienced will create their own frames of reference. And even to go to local countries, we will have experienced different things. So we need to stop assuming that we know best. Allow people to tell us what they need and to listen and support in the way we can, but also empower them to make their changes as well. Give them the tools and let them empower themselves and to make their own changes.
Thank you.
Yeah, I mean, echoing what's been said before, I think as the Red Cross and Red Crescent, we're fundamentally a local, community-led organisation. And not only do we have staff, but we also have 16 million volunteers that are drawn from the ecosystem of communities. And those volunteers include migrants and former migrants who are then engaged in providing services to migrants so that lived experience informs, creates trust, bridges cultural barriers. And I think that driving that work at the community level and supporting community organisations, including those who have lived experience of the issue at heart, is the way that this work needs to move forward.
Thank you very much for our panelists. So now I think we have maybe 12 minutes to the end, if I'm right. So I'd like to open for the question from the floor. I don't know if there is, I can see very well, the light is on my eyes, but yes, please, here.
I would like to start positive. You have a lot of very, very huge human skills that makes you very keen to help others and to alleviate all the obstacles and barriers against helping others. Do you think that we can learn from you and from people like you and organizations like you to know what makes migrant friendly?
Would like to reply?
Yeah. The question was what makes an organization migrant friendly? The characteristics. All right. I have one word as a psychologist: empathy. Empathy would be like stepping in someone else's shoe, as a person firstly, and then as an organization.
I mean, I think it kind of relates back to what I was saying earlier. We've started to see so many things as problems and as numbers. We've dehumanized situations. So it's very normal for people to then also be removed from the situation. So it ties into what Alexios is saying, which is empathy and to humanize situations again. But also, you know, a lot of the time I get people saying, oh, you're amazing at what you do. No, I'm human. And it is that. It's instead of putting people on a pedestal and saying you have to be something bigger to do that. No, it's human acts of kindness. It's helping your neighbor cross the street. It's helping your mother get the shopping in. But it's just doing it in a slightly different location. So it's actually minimizing what we do a little bit and saying actually anyone can do this. It is a human response to another human that is in need, and making all of these situations human again as opposed to numbers and problems.
It deserves an applause, I'm sorry.
Yeah, I think, I mean, as an organisation, we were born after the influenza pandemic in World War I, and we've grown from a small number of national societies to 191. And that growth has come from recognising how important it is to support those that are suffering and to alleviate that suffering and recognising the marginalisation in the world. I think What's also really interesting is that we're grounded by 7 fundamental principles, but just as Rebecca was saying, humanity is at the core of it. And just as Rebecca was saying about saving a life, there are multiple political dynamics to this conversation and the issue of migration. But if you keep humanity at the core and saving life at its core, then that's where it needs to start, and everything else will come consequently. But we're not even doing that. We're not even caring about saving life on the Mediterranean or in other parts where people are taking dangerous journeys. And I think we need to start with that.
Excellent.
This question.
Any other question? Yes, at the back, please.
Good evening. My question is, myself as a refugee, and I am witness about 1,000 good image from the refugees themselves. They integrate very well. But from you, our different sector are working with the refugees. If you just have a mediator from your sector to the government, just to reflect this good image that you touch it in person to the government to have good service, not only for refugees, because the problem they created, they say it is because of the refugees, but it's affect also the community themselves. But from you as a sector, if you are mediator between refugees and the government, what is your message? Thank you.
What's your message for governments if you're able to intermediate the negotiation between refugees and their governments? It's a huge... It goes far beyond the humanitarian help. It goes in the political arena, very, very complicated, at least in this period of so many conflicts, so many armed conflicts. But we've seen the humanitarian workers in the front line of all these conflicts and working very bravely, and we have to pray our honor for all that were dead recently in these recent conflicts. But would you like to say something about what message would you say to governments from the country of origin of people who are trying to find a new way? Take care of your people.
As the supermodels will say, ensure world peace. Nah, just kidding. Increase investment in education, mental health, psychosocial support would be my message.
Yeah, I think it goes beyond messages, because I think in our context particularly, they are fleeing violence sometimes, in contexts where there is a lot of insecurity for better living conditions, and what they find on the road is even worse conditions, because they are even victims of more violence and severe violence and sexual violence. So I think it goes beyond there, but I think it's important as well to raise awareness and to let people know and understand what is the real situation of migrants. And as everyone was saying before, empathy and trying to understand as well and to discuss with migrants themselves, because they bring stories that they makes you really wear their shoes and to understand that the difficult situation they're having in order to continue to the migration route. And I think it's very important to understand that first. So I think visibility and to understand the real situation is important.
I mean, for me, what we've seen is migration becoming increasingly politicized, and it's become a political football. People use migration to become elected, to try and stop other people becoming elected. And it just increases people who have already been through a lot. It increases their suffering. And actually, essentially, it's a human issue. You know, we are still talking about humans. And I talk from my perspective. I come from the UK, which is an island. Nothing is guaranteed in life. Just because I'm safe today doesn't mean that I will be safe tomorrow. No one wakes up in the morning and just decides that they want to flee and they're going to undertake a seriously dangerous journey just because they feel like it. People move because they have to, for a variety of different reasons, and it's not guaranteed that any one of us in this room would not have to do that at any point in our life. So to stop making things political, but to care at the root of that, which is a human. And it could be any one of us standing up here. It could be any one of us in the room. and to bring it back to that empathetic and to make it all human again. Stop using things as a political football and start caring about people. We're a really small planet in a very big universe, and none of us are getting off it. So we might as well care about our neighbors, whether they're here or on the other side of the planet, because there might be a day when we need to reach out a hand and have someone help us. So let's treat other people how we want to be treated.
I think speaking from the perspective of a lawyer, I mean, it ultimately depends very much on the context and the issues that are facing a particular population. But many states signed up to the 1951 Convention relating to the status of refugees. And there's a convention in Africa, and there's a declaration also in the Americas. And I think one of the key messages has to be that we stay true to the obligations as states that we've taken on and not necessarily try to circumvent them, because those obligations were taken on at a time of crisis when the world was at an inflection point. And we are facing similar situations now, and those obligations have withstood the test of time, and they need to continue to withstand that test of time.
Thank you. Is there any other question on the floor? I don't think so. So for these 3 last minutes, would you like to say in a few words what your final message for our audience? Maybe now starting on the other side of Sanjula, no?
I feel like I've spoken so much. I really appreciate the opportunity to be here and to have this conversation between health and non-health professionals. I think that bridging of that conversation can enrich the discussion that we're having and bring different perspectives and identify different solutions. I think to emphasize 2 kind of key points, I think this point around ensuring that the lived experiences of the people that we're supporting informs all the work that we do, including the work on this issue of continuity of care, should remain at the centre of our work. And I think there's a lot of work still to do in better understanding the capacities of not only our internal organisations, but also the external landscape. And there's a lot we can draw on if we work out systems to better coordinate and strengthen this work. Thanks.
Thank you.
Thank you for having me, but also thank you to all of you for being here and being invested in this topic. I think I'm just going to echo what I've said so many times before, so forgive me for being a broken record. While we continue to stigmatize people on the move, we're going to continue to sacrifice their health, saying that it's less important than their legal status. We need to continue making things, so we call them survivors on board because they are survivors. We need to have a survivor-centered approach, put them at the focus of their healthcare to try and ensure the continuity, but we also need to ensure support not only for us as non-governmental organizations, but also support for the organizations that have shouldered the burden of crises for so long, and just make the response human for us, recognizing the people on the opposite side of the argument, recognizing where their fears have come from and support them to change their views. But just remember that people are people, they're not numbers.
Thank you, Rebecca.
Yeah, thank you so much for the invitation and for the public to attend this session. I think, our context is a bit particular in Central America and Mexico. And I think indeed it's a worrying concern, and we see growing numbers in the region overall. So I think it's important to try to improve the medical humanitarian conditions for migrants overall, and for our context particularly. And it needs to be in a coordinated way with more presence of actors and as well some political willingness to access to a safe passage for migrants overall. So I think it needs to be coordinated, and for me it's important to just stress this. Thank you.
Thank you. Alexis.
I would say I got a bit pessimistic and depressed in the last decade, seeing all the aftermath and the effects of war on human beings, or seeing the death rates in my beloved Mediterranean Sea. So I came here with a focus to share the problems and barriers that refugees face. But I'm being honest, I'm leaving a bit more optimistic, just because I got to know you, and I'm really proud of your work and seeing that people like you are on the front line. So I'm leaving this forum with a slightly bigger smile than I came here. So I'm really proud of you guys.
Thank you.
Nice to meet you.
Well, thank you very much for our insightful comments from all our panelists. Thank you all for being here. Thank you. Congratulations to the Geneva Health Forum.
Thank you. For
Thank
having
you
us.
to our wonderful
Thank you.
moderator, and of course, to our panelists for participating in this invigorating discussion. Now, time to reveal the answer of the question that we were mentioning at the beginning. 84% of the people got it right, and the answer is D. Well, actually, this was strange. All answers are true. D. All answers are true. That's better. All right. Now, any final takeaway that you can tell us, Luis?
You were not.
I think all was said. Okay. Now, then I want you to stand up for a moment. Stand up and breathe. It seems meditation helps us lower the blood pressure and lower stress levels. Okay, time to wiggle our feet and walk around. We're going to have a 30-minute break, and be sure to visit the session that is right outside. We have a bunch of digital posters. We have a total of 200 digital posters if you swipe over there. And we have several of the creators of those posters in there. And they are all related to migration and health. So take a look at those, and we'll see you at 4 p.m.
Group picture?
Yeah, we'll take it.